I invite Dr. Sanjay Reddy for his next talk. Dr. Sanjay is a consultant diabetologist, Center for Diabetes and Endocrine Care in Bangalore, and also Fortis Hospital, Bangalore. He's a principal investigator in multiple trials on diabetes, obesity, and osteoporosis, and he's a vice president of the Primer Academy of Medical Sciences. Over to you, sir.
Thank you, Dr. Sheetal, for those kind words, and thank you, Dr. Purvi and Manoj, my good friends, for inviting me and asking me to share something. And it took me back, let me share my screen, it took me back to my college days.
Sanjay,
Where
I'm telling you, Manoj, actually, I finished the talk, but I think last slide I could not.
Yes, sir.
But it's fine. I'm joining again with the mobile, but I am there for the question answer for discussion. No issue. Thank you.
Thank you, sir. Thank you, sir.
Sorry for this.
No, not at all. Not at all. Please. Okay.
You can start.
I can start. Thank you very much, and thank you, Manoj and Purvi, for inviting me to speak on this journey of yours with insulin the last 100 years and what you put this program together. It's lovely to see all of you, and thank you, chairpersons. Thank you, Bansi, for the wonderful introduction to use of insulin. How to take insulin. So, what my job is to evolution of insulin delivery devices, boiling water to connecting. Takes back me to my old school day, college medical school days, where we had injection room posting. It was the most dreaded posting. You stand at 8 o'clock and you don't know when you're going to end. And I didn't know how many injections you used to give and how many syringes you had to boil. And accidentally you lift something which is very hot. You drop the syringe, it breaks open, and the matron comes and starts shouting. You doctors don't know how to give injection, and again you get trained by them. Anyway, we come back a long way, and I will stop exactly at 15 minutes. But please stop me at 7:45. I don't want to take much of your time. So, just a history of syringe and needles. Just going back, which came in first? Is the syringe or the needle? It's like the chicken and the egg. So, but here we have a clear answer. It was syringes were invented long before needles. This is from the Greek and the Roman literature. We don't know exact times. The first piston syringes were somewhere discovered, invented by Galen between 129 to 200 C. It was described by Galen. I'm not sure exactly on the date, but one of the first glass tube for suction of cataract was used by Anwar bin Ali, somewhere in the Middle East. 1650 hydraulics, where modern syringe was the hydraulic modern syringe which you have, where you can push, was invented by Pascal. But the problem with that type of injectable technique was they didn't know sterilization. It caused too many problems. 1844, the first hypodermic needle which was used, and that was by Dr. Francis Ryan at Dublin. 1853 was the first injectable IV insulin given by Alexander who did morphine, and 1950 use of plastics and disposables. The reason I went back to seeing this syringes in history is we wanted to talk about insulin use and the syringes, and we've been all talking about how from 1922 insulin was being given, but equally important was the delivery technique and how exactly this has to be given. Look at this. In 1924, it was BD who manufactured the first insulin syringe for insulin injection. Then the first 1925, the first Novo syringe, reusable glass and metal insulin syringe in 1954. And this was a saying in one of the books which is written, that this an anecdote which says a type 1 patient had to take 5 cc at the time. Her syringe had only 2 cc, so she had to leave the needle, inject, fill it up again and inject, and it would take 1 hour for her to again walk back to normal. Look at it from last 25 years. The delivery technique has changed, my friends. And how is it? And the first disposable glass syringes appeared called Hypack. That is 1954. First disposable plastic syringes came to market in 60s. Those by 50s, they had 54. They started use of plastics, but they had many drawbacks. Now we know all these drawbacks. We've been through, and those who have been as old as me and 25 years in medical school, by the time you started, you had seen all the type of insulin, all the type of delivery techniques which we've been used to. They were cumbersome, difficult to transport, and it was so painful to take an injection. Inaccuracy in withdrawing the correct dose of insulin, difficulty in mixing insulin wastage, stigma of injection, needle losses, sharpness, more pain. Now, there's a wonderful article written by Dr. Jyoti Dev, Dr. Bansi, and colleagues published in 1920. I know Dr. Jyoti is listening to this talk. I happened to read this article before I'm giving this talk, and he had put in the same topic, a similar topic, and enumerated the different devices and why there was innovation, need for innovation in insulin deliveries, in insulin devices. The need for devices is equivalent, the device is equally important as that of the insulin and the technique. I think three things: insulin, the device, and the technique, and education. Four of these things form the right way to take insulin. So we needed them because of all these. We all know these painful things which happen: poor compliance, painful and cumbersome, long needles. We came back from 8 mm needles. You saw Bansi presenting. We had 8 mm needles to now literally 4 mm needles. Probably we go to a point where there could be needleless delivery. Probably that could be a dream. Poor safety for patients, chances of more hypoglycemia, poor glycemic control, and patient dissatisfaction to lesser painful injection, improved compliance to regimes, fewer hypoglycemic episodes, better glycemic control, patient satisfaction, improved quality of life, cost savings, improved convenience, ease of use for the patient and the caregiver. Now, this is the evolution of insulin delivery devices. This from 1922, from the time insulin was discovered, we had innovations in delivery techniques from the insulin syringe from 1924. Then we had the first disposable glass syringe. Then we had the first pump. Then different types of insulin delivery. Is it not? Pump is also part of it, one of the insulin delivery. Introduction of these permanent pens called NovoPen. Then you had insulin Eli Lilly's pens coming in. Then you have manufactured from Sanofi. All of the companies which were manufacturing insulin came out with their individual pens to make sure that the cartridges fit in them. The technique has been the same, but there has been improvement in these techniques over the years to now connecting devices and pens. Pens which can read, which can talk to your cell phone, say whether how much of insulin you're taking, a few words about all of these in the next 10 minutes, 5 or 7 minutes, and then we can end. Now, this is the first pen, the original Novo pen in 1985, first ever insulin pen. It was like, I'd seen people carrying it from across and say, I'm using pen insulin, but we didn't have cartridges. I really don't know when exactly we had cartridges, but pens were available from 1985. Now you have pens like, these are the different types of pen: Huma pen, Flex pen, Novo pen, Royal, Solar Star. You have pens which can deliver even zero point 0.5 units, especially in children and type 1 diabetes patients. Flex Touch, Insupen, we all have seen these pens. Now, please remember, each pen has to be prescribed with a cartridge which goes with the pen. Please don't mix up cartridges and pens, which is a very good thing. Now we have, and one of the pens to deliver even a GLP-1 analog, which I found very nice, is the recent one, which the dulaglutide, which goes in like, it's like spacecraft. You can't even see the needle. Hope we have pens like that to deliver insulin, so the patient doesn't see the needle, but still can be reused. Now we have two types of pens: the durable and the disposable pens. You all know the durable pens are pens which you can reuse. You have cartridges which we can put in. They are less economic. They are more economical than the disposable pens. The disposable pens you use, especially in short-term use, when you want to initiate insulin, pregnancy patients, patients who are hospitalized for few days, where you need to give them insulin, patients undergoing surgeries, patients who have difficult handling the cartridges in reusable pens. These are the people who take disposable pens. But the durable pens, these are all for long-term use, and some elderly people which come in clinical practice still want to take a vial and the syringe. Please remember, still existing, more than 60% of our patients in our country use syringe and vials. Please use the right vial with the right strength of insulin. Usually, previously we had insulin, which was 40 ml, 40 units per ml and 80 units per ml. Then it got standardized to 40 and 100 IU. Some countries we don't have 40 IU. In our country we have 40 and 100 IU. There's also 500 IU in the US, but 40 and 100 IU. Please make sure that you use the right syringe with the right dosage. And now, with saying this, why I want to repeatedly tell is one of the most important thing is educating. Now, these are connected pens. This is the in-pen system. It was approved by FDA in 2016. Now, this has a bolus calculator, real-time insulin on board tracking, dose history. Whenever we injected, there's a history how much of dose you were injected. It definitely improves compliance, especially many people. It can give you can set reminders. Similarly, you have NovoPen 6 and NovoPen Echo Plus, which automatically record the dose of injection insulin injected, and then data can be shared with collaborating CGM device or into a diabetes management app, or can be shared online to an EMR. I don't know if that is possible. I think that would be the next, if they can talk to your phone, talk to the type of app, and also the EMR. Now, this is what in future you're going to look at. You have connected devices. You can calculate how much of insulin they're taking, when they are taking, how many doses of insulin they missed. I think that improves compliance, and that could be the future. Now we have this evolution of pumps. This is where we are from a pump with this much, and we've seen these figures over a period of time from 60s to present day. There's a huge improvement in pumps, and I'm going to just talk a few words, because on paucity of time, we have pumps which are weighing more than 400 grams to now pager-sized pumps, wireless experience, large screen where the displayed information is easy to read. Patient can program several different basal rates to be used in one day to accommodate diurnal changes. Smart pumps, insulin pump that can work along with the continuous glucose monitoring system. So a few words about them. Now you have the pump patch, the Omnipod, which is tubeless, can be worn up to 72 hours. It's controlled by a personal diabetes manager that also functions as a glucose meter. Now we have also the Omnipod Dash. It's an insulin management system, FDA approved in 2018, a tubeless, waterproof, Bluetooth wireless technology pump with a capacity of 200 units of U100 insulin, and updated touchscreen PDM that regulates the pump, and it can be connected to one of the Contour Next One glucose meter. Now, this is automated insulin delivery systems are from a continuous subcutaneous insulin delivery system. We're going to from an open loop, hybrid loop, to a fully automated closed loop system is where we are going. And in the future, I think the future is exciting if you have the means and the need of all of patients can afford it. Now you have a sensor augmented pump here. It combines the CSI delivery and CGM. The CGM data sent wirelessly from the sensor to the pump, which can display glucose values and trends. Insulin delivery is adjusted in response to CGM data. You can do it either manually or you can set it automatically. So this is one.
Sorry to interrupt. We are past 7:45.
45. Yeah, I've just passed. And then you have the hybrid closed loop system, combines user delivery and premier insulin. This MiniMed 760, a fully closed artificial pancreas at a glance. You have a sensor, receiver, a control algorithm, and an insulin pump. So what I want to say is this is one which got the Beta Bionics is the one which got an emergent. It said just put in your weight, we'll take care of the rest. It has both insulin and glucagon. It has a control system, a glucose measurement, and a subcutaneous delivery system. Now, do-it-yourself artificial pancreas. I said we're not going to wait for the results. If the devices are good, we're going to use, and that's the new thing. And then you have an implanted pancreas, which is a fully implanted insulin device. It's a novel AP technology. It's a gel-based one, and the stage of development is not yet. And you have all these apps and how comprehensively all this can be connected, and these devices. Now, we all know from glass syringes to different reasons, and we have come through all this. We have diabetes management systems which are going to change the way you're going to technology delivery systems. Probably tomorrow, non-injectable delivery technique will come in from the long way ahead from 1924. But remember, the most important thing: you have insulin, you have delivery devices, you have the best insulin, you have delivery and monitoring devices. Until the patient is educated in all of this, I think they will not work well. Thank you very much.